welcome, everybody. It's a great pleasure to see you here to the first session in this year's edition of EBC. My name is Jens Lassen, and I'm chairing this session with my very good friend, Yiannis Chatzizisis. And we are very, very happy because what we are discussing now might be the future. And this is what it's all about. With us today, we have a panel, Goran Stankovic, Francesco Burzotta, Yves Louvard, Tinen Iles, Claudio Chiastra, and Nicolas Foin. All of us to discuss what we will see today. And of course you. So please raise your hands and ask questions when we have the time for it and participate actively in the discussion. But with that having said, I think we should get started by inviting Claudio Chiastra to give the opening talk. Claudio.
Okay, so good afternoon. Thank you very much for the invitation, and thank you very much for the introduction. So I will try to make this presentation about simulation and the use of artificial intelligence for coronary bifurcation treatment, and to talk about the state of the art about this. So there are two main computational approaches for investigating coronary bifurcations, physics-based modeling and data-driven approach. On one side, the physics-based modeling relies on established physical laws of cardiovascular physiology and biomechanics and uses computational simulations to investigate structural mechanics, hemodynamics, and transport phenomena. On the other side, on the right, the data-driven approach leverages large data sets and artificial intelligence methods to identify patterns, predict clinical outcomes, and support decision-making. And we'll start briefly discussing about the physics-based modeling. So simulations and physics-based simulations allow to compute quantities that are hardly detectable or even impossible to measure in vitro and in vivo. There are different simulations types. First, structural simulations or finite element analysis of stent deployment, like the simulation, the example that you can see here, which enable the quantification of geometrical indexes, like malposition, MSA, side branch osseal area, the stress and the strain in the arterial wall, and also the arterial wall damage provoked by the expansion of the stent, by the expansion of the balloons. And finally, it allows to compute the stress and the strain in the stent. All these quantities cannot be computed locally in vitro or in vivo. Second, computational fluid dynamics simulations, which enable the investigation of the hemodynamics inside stented coronary bifurcations, and allow computing quantities like the near wall quantities, for instance, the wall shear stress and all the related indexes, but also bulk flow quantities like the pressure and the velocity fields, but also more advanced quantities like the helicity and vorticity. In this example, you can see a coronary bifurcation treated with a kissing stenting with two inner channels with increased velocity of the blood because of the presence of the metallic carina. And on the right, you can see the corresponding wall shear stress contour map with blue value, which indicate a very low value of wall shear stress, which can be linked to the risk of in-stent restenosis. And at the bottom, you can see the recirculation zones, for instance, at the level of the metallic carina. It's also possible to combine and compute at the same time structural quantities and fluid dynamic quantities through fluid structural interaction simulations. These simulations take into account the distensibility of the arterial wall, like you can see in the movie on the right, but they are very complex simulations, and there are few applications for coronary arteries at the moment, and there are no applications yet to stented coronary bifurcations. And finally, we have drug transport simulations, which can be used to quantify the drug concentration inside the vessel wall, so distribution, depth, and kinetics of the drug, And for instance, here I'm showing an example of comparison between 3 different techniques. So provisional side branch on the left, culotte stenting in the middle, and culotte using the Triton stent on the right, showing the drug distribution at 4 different time instances, so from 1 hour to 2 days. And you can easily appreciate how the drug distribution is different depending on the stenting technique. So what are the main applications for the physics-based simulations? First, virtual bench testing at the top. Second, patient-specific simulations at the bottom. Virtual bench testing can be used for stent design and optimization, for comparison and refinement of stenting techniques, for preclinical evaluation of novel devices, and also for education and training. And in this sense, virtual bench testing is complementary to the in vitro testing. So after this session, we are going to have another session on in vitro testing and virtual bench testing. Then we have the patient-specific simulations, which rely on clinical data, in particular on imaging data, in order to reconstruct the models and then perform the simulations. And these simulations can be used for pre-procedural planning, outcome prediction, potentially in the future for virtual clinical trials, partially refining or partially replacing the conventional clinical trials. And then again, they can be used for education and training. Just to make some examples for the applications of these simulations, for the virtual bench testing, I show this study that we conducted in order to investigate the impact of the wrong positioning of the Triton stent, when that stent was available, on the biomechanical quantities. So we virtually implanted the stent in 3 different positions, 2 proximal, in the correct position, and 2 distal. And then we compare the 3 different scenarios in terms of geometric quantities and structural mechanical quantities. Coming to the patient-specific simulations, I start with this, with the John Doe program, which was supported by EBC around 10 years ago. It was a collaboration between 3 different institutions, Erasmus MC, Ghent University, and Politecnico di Milano, where I was working at that time. And we considered 1 patient with a significant left main stenosis. We reconstructed 3-dimensionally this bifurcation by fusing CT and Ives, and then we virtually replicated the stenting procedure that was applied to the patient. So basically, we followed all the steps that were applied to the patient in the real life. And then we compared the results in terms of geometric quantities, structural quantities, and also fluid dynamics, considering the use of pot, so with pot or without pot. Nowadays, patient-specific simulations can be used for pre-procedural planning. A nice example is the one by Professor Chatzizisis about the planning of left main interventions. He is going to discuss this study later in his presentation. Just briefly, it's possible to create 3-dimensional models of the coronary arteries, coronary bifurcations, from angiography and Ives, including also the plaque morphology and taking into account the different stiffness of the plaque. And then it's possible to perform the structural simulation and the fluid dynamic simulation prior that the stent is implanted in the patient. So just summarizing for this first part of the presentation, there are different types of simulations that can provide us information intra-deployment and post-deployment. They can evaluate quantities of interest that cannot be captured by other methods, and they are adaptable to a variety of scenarios. Of course, these simulations come with some disadvantages. First, there is uncertainty in the material properties of the artery and the plaque. They are sensitive to assumptions, simplifications, conditions applied, and the computational time may be very high, especially for the FSI simulation. Now, moving to the data-driven approach, today we are seeing the rise of artificial intelligence with a mass adoption of generative AI since ChatGPT launch in 2022. Consider that only for ChatGPT there are 300 million weekly active users today. We are seeing a rapid expansion across different sectors of the use of AI, from education, law, business, but also healthcare. We are seeing also an increased use of AI in science. Look at the plot on the right. That is the number of publications in which AI was used over the last 10 years. During the last year, we reached almost 1 million publications in which the term AI was named. So scientific disciplines are being transformed by the use of AI. The most striking example is the one of AlphaFold, which is a software used for predicting the protein structure, which was at the basis of the Nobel Prize in chemistry of last year. AI is used also in medicine for different tasks: medical imaging, clinical decision support, genomics, drug discovery, and healthcare workflow optimization. And specifically, in the context of cardiovascular intervention, AI can be used for 3 different tasks. The first one is image analysis, and I just showed this example about feature detection from OCT using the Pulse medical imaging technology software. Second task is risk prediction, and just mention the price score, which was published a few years back in Lancet, and it is a machine learning-based approach for the identification of predictors of events from acute coronary syndrome with a very good performance. And finally, third task is procedural planning and guidance. And I mentioned this AI-assisted Ives imaging system from Boston Scientific. Regarding the use of AI for investigating as a support tool for coronary bifurcation treatment, there are few specific applications available at the moment. There are some examples related to image analysis, and I show on the left this example, this AI-based PCI software, which is able to identify the coronary bifurcations and the coronary bifurcation lesions. Then in the following presentation, there will be an example also on the use of AI for coronary bifurcation in the context of coronary bifurcations for education and training. AI can be also used for speed up the simulations. And on the right, you can see an example of using deep learning in order to estimate the wall shear stress in a very rapid way without performing any computational simulations. However, in this area, we are very far from a robust clinical application. So just to summarize the pros and cons of computational approaches, for the physics-based approach, they are grounded in physical laws, they provide mechanistic insights, they allow modeling complexity, so this means that they can be used for analyzing patient-specific scenarios, and they can model what-if scenarios. However, they require complex modeling, they are sensitive to boundary conditions and assumptions, they require verification, validation, and uncertainty quantification, and this is also needed for the regulatory approval of the devices. And they are computationally expensive in general. On the other side, for the data-driven approach, this approach can capture complex patterns from large data sets. It enables fast predictions. It is useful where mechanisms are not fully understood, and it is adaptable to the real-world data. However, it requires large, high-quality data sets, and this is a huge problem in our field, in medicine in general, acquiring high-quality data sets. It may lack interpretability. there is a risk of overfitting or bias. There is limited extrapolation beyond the training data. And these considerations leads me to concluding the presentation by introducing the concept of digital twins in healthcare. Digital twins are virtual representation of a physical object, process, or system across its life cycle. Digital twins are common in the engineering fields, but they can also be translated in the field of healthcare. So when we talk about digital twins in healthcare, these tools use data and models to enable learning, reasoning, recalibration through a dynamic or human-in-the-loop approach for monitoring, diagnostics, and prognostics. And the digital twins can combine both AI-based, so data-driven approaches with computational approaches, so with physics-based approaches. And they can support the entire clinical workflow, from data acquisition to diagnosis to therapy. So we can have models to minimize data artifacts and optimize acquisitions in order to provide optimal clinical information. And we are talking about data in this case. We can have models to analyze and interpret data to provide robust biomarkers and predictions, and we are talking about diagnosis in this case. We can have models to optimize device settings and intervention choices to provide optimal devices intervention to the patient, and we are talking about therapy in this case. So I make you a question. So are we ready to create a digital twin of the coronary bifurcation which can incorporate both physics-based and data-driven approaches for monitoring, diagnostics, and prognostics? And I would like to end my presentations with the objectives of the session in order to have a good discussion towards the next two presentations. So first point, we would like to brainstorm the clinical utility of computational approaches to support coronary bifurcation interventions. Second, we would like to discuss specific applications of physics-based and AI-based models leveraging invasive or non-invasive imaging. Third, we would like to assess the feasibility of real-time applications based on computational models. And last, we would like to explore strategies to maximize the impact of computational approaches in transforming coronary bifurcation treatment. And with this, I would like to thank you all for your attention.
Thank you very much, Claudio, for giving this excellent overview and for setting the scene exactly where we want it for the rest of the session. Thank you very much. We will save questions to the end of the session, so please just note them if you have them. And now I would like to invite Yves and Ilic to come and give the next talk on left main AI-based PCI learning tool.
Dear Chairman, ladies and gentlemen, thank you, Claudio, for this comprehensive introduction. I would like to get more clinical in presenting a proposal for a clinical study that will address left main AI-based PCI learning tool. These are my conflict of interest. And basically, you know that left main presents a completely different coronary vessel, different from other coronary circulation in terms it has large diameter and caliber and has a specific atherosclerosis that develops from the lateral sides of the main branch towards the distal main and the side branch in terms LAD and circumflex. Also, the angle of bifurcation is very specific. It's almost 70 degrees and it's completely different from other bifurcations. And what is most important is subtends a large territory of myocardium, which means interventions in left main are clearly demanding, technically demanding, and difficult to learn because you cannot learn it in practice, which makes it a very interesting topic for a young interventionalist how to approach this issue. The aim of the proposed study would be to create an AI-based virtual tool for training left main PCI based on CT characteristics of bifurcation and actual interventions. And the study methodology would include initially 300 patients that undergo pre-procedural CT and afterwards left main PCI, And the data will be collected in a registry, which will help us to create an AI-based model that will be fed with the information based on data acquired by CT, which will lead us to create a virtual model that can be furthermore validated on 100 patients that will be prepared for PCI and offered to an interventionalist to be trained using this model and to decide which strategy would they use. The data that will be collected from the CT, they start with vessel diameters, and we want to know the size of the main and the side branch in terms that left main PCI, just due to the different vessel sizes, is very demanding. Furthermore, we would like to find out the plaque volume and its distribution, and specifically address plaque composition in terms of its thickness and the content of the calcium. And furthermore, we need to find out the bifurcation angles, as it has been shown in the studies, that bifurcation angles can substantially influence the outcome of the procedure. And regarding the PCI, we would like to collect the data on the planned bifurcation strategy, imaging use, whether it's IVUS or OCT, and another adjunctive techniques like calcium treatment that we use to treat the patients. Also, stent selection and procedures afterwards used, like proximal optimization, kissing balloon inflation, should be collected, which also we need to know what happens with the strategy after initial stenting, whether there was a change in the initial strategy or the strategy was pursued further. And also, we need to collect the procedural data, fluoro time and contrast use. Afterwards, the direct success of intervention would be recorded, and further patients followed for long-term follow-up. And this data will be introduced in a deep neural network model that will be used to extract the data about the vessels from the CT and then further translated into the model that can be analyzed and used to feed the model and train it, and then further allow training of the interventionalist. The model would include distribution of the atherosclerotic plaque and can also include the physiology of the left main bifurcation, which can lead us to provide a tool to plan the procedure and execute the procedure and see the immediate results. What we want to know is procedural success and complications of the intervention, together with the data on the procedure itself, but it can be also used to gather information about the long-term MACE events in our patients, which can also be further used to assess the procedural success and the technique used to treat bifurcation. And also here we present an additional tool where you can create a virtual 3D model that can be used in real time for training, where you have tactile feedback on the coronary guide wire using a 3D camera that is placed on the chest of the operator, and then you practically can, of course, if you develop such a computational model, an training operator can use this 3D camera to just to train, to manipulate with the wires and get better in treating bifurcations. And in the end, this, if in the future, can create a large database of left main CTs and PCIs that can be used for AI model creation, but can also be used as a model to test further in the future different techniques or devices that can be used to treat bifurcation, and can also become an endorsed training tool for left main PCI. But in the end, there are a few questions that have to be answered. Is there really a need for us to have such a model? Do we really need it in our daily practice? And also how to create it. Is it feasible to create a model that can encompass so many different information, different morphological techniques to assess coronary arteries, and how to implement that in a model that can be used in daily practice. Thank you very much for your attention.
Thank you very much, Ivan, and thank you for raising those really important questions in the end. So maybe we should turn to the panelists now and discuss, has time come for introducing AI big time in medicine, and is it feasible to do it? And we could start with you, Goran.
You know, I can comment on use of data set because I attended last year anchor meeting in Korea in which Dr. Koo presented some of the models based on AI analysis in acute coronary syndrome. He will present, I think, tomorrow here the same one. So for that purpose, I believe that we should join effort and combine brainstorming between European and, of course, Asian or US teams, and then work on the same project. For the education, I think that simulation really made fantastic step forward because based on simulation-based training, at least in Europe, became part of the routine process. And if you look at EuroPCR, for example, in the training village, you see long queues of young people trying to work on simulation and go through the steps of complex procedures. And this is, of course, especially true for bifurcation with variety of different steps. At least we represented DK crash with 11 steps. You can make mistake at any. And for educational purpose, I think it's already something that is integral part. But for that, we need support from the industry, which opens another area.
So work in progress, Goran. And we do have a lot of good starts, and they have shown us something in Korea that really is encouraging for the time. But what work in progress?
So my perspective is that we are always claiming for the support of industries in supporting us, but the truth is the fact that we should develop a shared request, I think, to the industries. Because if we review the two presentations of today, we see that there are still many potentialities that have to be explored. On the opposite, as you mentioned, for education, the fact that you train a physician in incorporating in his mind, her mind, the steps of a procedure, his ability in selecting according to the different anatomies. All of this probably is already ready to enter the education, but as a scientific community, we should state this and incorporate in the education, at least in Europe, I think. And if I am part actually of the EPCI training committee, and still there is no official track for this, and probably is at that level that we should request this, because the facilities are there and they should be, I mean, prioritized before the young doctors engage in treating the patients. On the other side, regarding all this stuff that is probably, I mean, really fantastic and stimulating, honestly, I tried several times to develop some thing that may have clinical meaning, and so far we are really still finding problems. The number of cases, different cases that are needed to really feed the artificial intelligence is a huge number most of the time. And this is something that, again, should be incorporated in our planning, because this means that we should put together the data. This is another important aspect.
So both of you underline that actually in educational purposes, it actually seems already there, but it needs to maybe be coordinated and developed a bit more. And what about directly into online procedure planning would be the next step. But one thing that, just to make some short answers on this, what about the feasibility? So I would like to hear just very quickly from the three of you, do you think the methodology is at a stage where we can use it now and where we can really start up and believe in what we're doing? Are we there? Is it feasible? Tinen and Iles, just and please just short answers. Give us an idea of where we are.
So I think as far as the feasibility of using AI, I think it's feasible for more of a function for understanding how a system is working and to be able to identify pitfalls and downfalls within complex cases specifically, or things that are non-obvious that are maybe difficult in capturing, and something that we use the AI, or even more specifically using explainable AI, so we can use wide data sets, and so we can try to better understand what's driving the system and what's the different factors that are actually contributing, and then using that as a knowledge base for the treatment, and also maybe combining that with imaging. Yeah. Sorry, maybe that wasn't short.
And what about the machine power we need, Claudio? Do we have it?
Yeah, I think the machine power is not the problem. We can have the machine power. Companies that work with AI can have the machine power. It's not that a problem. I think the main problem for AI at the moment was mentioned by Francesco Burzotta. It is the data are the problem. So we need to have huge data set, high quality data, controlled data. So I think a community like this is very important in that direction.
So this is where we should join forces to create those data sets so we can actually develop the techniques. Yeah. Nicolas?
Yeah, maybe outside of the research and simulation, I see a real potential of AI for decision making and guidance, including real-time guidance, because most of the interventionists, they're actually quite, sometimes it's dark for them what they should do, how they should do a specific technique, so there is a role to play. And on the capability, I had a talk on AI recently where I show this graph. Today, for like $1,000, you reach the computational capability of one human brain. But in 15 to 20 years, for that same amount, you will reach the capability of all human brain. So, AI, and it's going to be beyond us. It's going to, for sure, have an impact also in intervention. So we need to embrace it now, because otherwise, it's going to progress in all the different fields, but we're going to stay a bit behind.
Thank you very much. It's actually a very, very fine way forward for you, Yiannis, now. Because now we can discuss, is it feasible, and can we do these things, decision support, imaging, evaluation, can we do it online? So
let me. It's a pass to the next.
Yes.
To the next talk. Thank you. Let him go there. All right. So thank you everybody for attending this. I think it's thought-provoking, forward-thinking session, and very happy and pleased to be among friends. Can I have a presentation? Please? Or I can just say it. I remember it. While you're trying to load it, yes. So these are my disclosures. So we're going to discuss about a case, and we'll walk through this together with some breaks here for discussion, and everybody is welcome to step in. We have the next few minutes are all ours. So very brief case, AI and simulation guided PCI. Let's see how real and feasible this can be and how much is needed, of course. Again, that's my disclosures. A 60-year-old woman with symptoms, all risk factors of the ward, ischemic cardiomyopathy, prior stents in the RCA and LAD diagonal. MRI shows viability in the LAD territory. And that's her presentation here, angiographically. You see here the distal left main, again, prior stents in the LAD and the RCA, diagonal as well, viable LAD territory. Obviously, the patient was discussed with the surgeons, and of course, the patient finally, after balancing everything, declined. That was her preference, the surgical route. And now the ball comes to us to tackle this distal left main disease. And I would like to ask Yves here, do you feel comfortable to just go ahead and do the PCI, or you would like to have some tool, some guidance from AI to tell you how to prepare the lesion, what stent strategy, what stent size?
So I heard in the discussion, I heard that there was training. Yes, training, but training for which technique? And the same for planning. Planning, but for which technique? Do we have enough information today to explain why there is always a restenosis at the circumflex? When there is a restenosis, this is at the circumflex. Why? Maybe you don't remember, but I send you a potential reason for that. I will resend. So I think if we have the potential of understand what is creating this restenosis at the circumflex or closing the cell if they have not been removed, I think this is of major importance, urgent importance. Okay. Because we are doing left main intervention since a very long time in the late 90s. And today we still have the same kind, always restenosis at the circumflex. Less than 10%, but okay, we don't, for left main, we don't ask for 10%, we ask for 0 or, a mistake.
So you would like to have, if I interpret well what you say, you would like to have a tool that predicts your outcome to the circumflex and gives you confidence.
Yeah, you take the whole database, the major database there, and you will find if there is a correlation between the stenting at the end, the diameters, the position of the corona, and so on, okay, is related to what we see in the circumflex. Why this patient has a restenosis circumflex. So for me, this is, of course, we have to train young people, but if you train with a DK crush, I never did a DK crush, I did a lot of left main. Is it wise to, in Europe, at least in France, it's probably not useful to train DK crush. But, for me, is before having a guidance, you need to know what is the best procedure, what is in details, If you have a proximal LAD with the same diameter as a left main at the end, if you don't remove the strut, this is a factor of cell closure, I'm sure.
Exactly. And then I guess you feel that by having this tool that informs you about the best approach to achieve the best possible outcome, this way you expect to reduce the trial and error phase that we all do in the cath labs and learn on the patients essentially by trial and error. And maybe give you some confidence for techniques that you don't use routinely, but you get this confidence now from the prediction. Right? It's a question?
Yeah, I'm always using the same technique. I was. Today, in my dream only, but I'm not using, I was always using the strategy. I never did a decay crush, never, was always provisional. So, and of course, as usual, as other people, I have some percentage of stenosis. So, when we train somebody in our center, we train for provisional and all these details, but some details are missing, still missing. We have to find what are the details and to remove them in order to have 100% success rate.
Goran. Quickly.
Two things. One, I heard from one of the operators that if you want to make procedure more predictable, you have to take decision-making process from the operator. And I guess that this one should go in that direction. If you just show us this angio, it does not seem to be very complex, but what could be helpful for me is maybe CT evaluation before that will allow me to understand all the points addressed by Claudio in his presentation. So it's plaque composition, distribution, bifurcation angle, optimal view in which I should open bifurcation to make procedure more predictable, and practically before even starting procedure to have in my mind a clear understanding of the steps that I need to perform and the projection in which I need to work. And regarding the strategy, for us in simple left main bifurcation, I think stepwise provisional is something that we really believe is the best way to start. Because so it's open sequence of steps, so you don't need to decide upfront the third or fifth step. You actually just start, optimize the result in the main vessel, and then proceed.
So you ask for imaging, and essentially here is the imaging. It's invasive imaging. As you can see, this is the proximal, on the top left, the proximal left main, then the distal left main with a lumen at 4.9, ostial AD 6.6. So it seems like distal left main to ostial AD looks that it has some disease, and then circumflex 7.3. And you asked about you want to know more than that, on top of the lumen, the material, and here is now the AI tissue characterization that tells you the wall, the lumen. You see the blue is the calcium distribution and the arc there, and the fibrolipid. So all this information now is superimposed in a second on the IVUS, lumen, wall, and all the tissue pretty nicely characterized. It's all AI powered. And now the question that goes to you, Goran, since you initiated this, is how does this AI-driven IVUS, OCT, or CT tissue characterization, how does this enrich your ability, and you're expert on imaging, but others are not, on the ability of everybody to understand and interpret imaging?
You know, I have to say, I still remember Volcano and his virtual histology. That one was a good idea, but I don't remember if it really translated in clinical benefit in ongoing trials. But in this specific case, if you see that there is really a low amount of calcium, short arc of calcified tissue, it can really help me plan the steps of lesion preparation. So it means I don't need dedicated system. I can start with NC balloon. Based on the imaging, I know the size, the reference, proximal and distal, the length of the stented segment. So I can plan preparation. I don't need to repeat imaging after preparation, probably. I know that with such a small amount of fibrocalcific tissue, with one-to-one predilatation with NC balloon, I'm ready to position stent. And then I know the boundaries of stent platforms and the expansion capacity and the reference diameters in the landing zones, proximal and distal.
Excellent, excellent, yes.
If we come back, can you show the image of IVUS? So I can pose you a question in terms
Today
of...
it's only me asking, but anyway, let's
yes, since you interrogated the panelists, I want to interrogate the speaker. So if your heart team suggested cabbage in this patient, okay? If now that we see this IVUS, I see that there is a really limited plaque burden, and we have borderline significance for lumen area stenosis, not in terms of guidelines, but in terms of correlation with possible ischemia. So it is possible that this patient cannot be, let's say, discussed about the possibility to be revascularized, but I would be really, really interested to know from an AI machine which will be the benefit of offering a cabbage with these borderline hemodynamically significant lesions, where it is possible that the cabbage will not work every single day unless the women will run. And this creates the problems for some disturbance in the efficacy of work of the bypass we administered, we created. And this can have an impact because I have experience of many patients with borderline hemodynamic significant lesions treated by cabbage coming back with still angina and not properly functioning cabbage. So this is probably something that can be simulated and this is probably very difficult to be answered on the basis of trials, because we know that there are some patients benefiting of cabbage and some others by PCI.
Correct.
And this is the typical condition where you can have something that cannot be answered. So in this patient, what you expect, if everything will function, cabbage or stent, which will be best for this myocardium.
Very good point. So we need prediction not only for the technique, for the PCI that we're going to have today, obviously we'll discuss today, but also about the outcome of with surgical
theoretical outcome according to the
medical,
the
right?
different options we have.
Very good. So here we now we pause. We took the patient off the table, and I will go to the route of planning. From the body to the computer, digital twin creation. You see here a combination of angio and IVUS, lumen, wall, 3D reconstruction. Again, a digital twin, very faithful anatomical and physiological replica. You see the 3D physiology, the flow acceleration across the carina here, systole, diastole, every bit. Very important information. You see that the flow to the circumflex looks okay. It's only the distal left main the problem. And then here is now the 3D biology, because the brain is 3D manufactured, not 2D. And then you see the one is the proximal left main slice, the 2 is the distal left main, the 3 is the ostial LAD, and the 4 is the ostial circumflex. And you get to see now here the distribution of calcium in 3D, okay, coming from the IVUS images, and integration of angio, now very faithful replica of the biology, and then also the fibrous tissue. So now you have the whole concept of the tissue and the lumen and the wall in front of you in 3D. And one step further here is to move from material distribution to stiffness, which makes essentially takes all the material, the complexity of the calcium depth and circumference and fibers and so on, to convert it to a simple number, the stiffness, how stiff it is. Against stiffness, this is what stent essentially faces, the stiffness of the wall. And you see here the fibrocalcific nature of distal left main. It's a spectrum of stiffness. And then one step further, you can have essentially a map on the right-hand side that tells you that based on this stiffness, the predicted lumen gain with a simple balloon predilatation versus more advanced techniques is X and Y. In this way, you can essentially have a tool that, based on the anatomy and biology, gives you a prediction of what device to use to predilate, to prepare this lesion to receive the stent and have a nice expansion of the stent, a nice outcome. So I'm going to pause it here, go to Claudio, and ask him, how do you see this tool in terms of like its need, clinical need? Because now you have a tool that gives you the stiffness. Do you need it to guide your lesion preparation? Or you have all the information on the IVUS and you don't need additional information?
I think it is very important, it is needed, because it's not only the morphology of the plaque, it's also the material of the plaque. So basically, you can have calcium of different shapes, but you can have also this calcium with the same shape, but different stiffness. And so your device is going to react in a different way depending on the both plaque morphology and material characteristics. So yes, to answer your question.
Nicolas, would you like to know the stiffness?
Well, the stiffness is important, but I think one key question is how do you make this tool in real life? Like, how do you make this tool in the CAD lab for daily use, where you cannot have the stiffness, you cannot have necessarily all the information ahead. So I think this is where we have to cross the chasm from the experiment, the research, to what kind of tools could be used more broadly. And I think that's what we have to aim for, where you have maybe angio, CT ahead, and it has to be simple enough so that you can have a wide application of it.
But is it worth it to go this endeavor to come with these tools that predict the stiffness and the lumen gain? Is it worth it? Because there's the end point, and there's how you get there. Obviously, how we get there, we need big data and lots of analysis, but is it worth it, all this mega effort to get there? Or we have all the tools available now and we're good?
I think if it's simple enough to use, it's worth it. And it has, I think that's the most important point. It cannot stay only research if you really want to use it. So it has to be simple enough to be
translatable, to be clinically applicable. Yeah. All right, so let me now go to...
Yiannis, sorry.
Yes.
I think, however, the concept of stiffness is something new, because actually what we are doing into the cath labs all over the world is to evaluate the amount of calcium. But as previously mentioned, not all the calcium reacts in the same way, and probably sometimes the presence of some calcium in a specific spot, together with a lot of fibrotics, can create a stiffness that is much higher. So, to me, this is a new concept, the idea of coming out with the stiffness grading, but, I mean, are you able doing? I mean, are we able doing a stiffness analysis that is realistic? At the end, what we want is to understand if we will be at a certain point able to expand a non-compliant balloon. We know that this is the critical point of a PCI intended to end up, even with the drug-eluting balloon, but for sure for stenting. So this is... Can we imagine that there is a stiffness that is the threshold for good reaction for a non-compliant balloon? Do you think that is possible?
I think it's possible.
Okay.
It is possible. Absolutely.
You know, most operators inflate NC balloon to test the lesion, actually, and then make
what did you have now? What did you have now?
I know
but what now? You have a tool that tells you already what would be the expected
I just said,
response.
you know, when you see plaque distribution, it's exactly what we learned 20 years ago from Renaud Virmani. Lateral wall, so calcium in the lateral wall opposite to carina. Planning from that perspective, I mean, it looks nice when you see it, but even if you see angio, you know where to expect, and you see if there is calcium or not. If your strategy is to predilate with NC balloon and test the response of the plaque, I think this is probably useful additional information, but not really something that will dramatically change.
The question, Goran, is do you feel confident that everybody knows on this planet? Because you are experts. You guys here are the super experts of the world. You write the guidelines. Does any plane of the fellowship interventional cardiologists know this? Or she has to learn this by trial and error on the patients, which comes with complications? Yeah, that's the question.
To be honest, you know, shift from NC balloon, which is this cost, to immediately go to IVL, which is this cost, without testing the response of the plaque to balloon inflation seems to be 7-mile step, you know.
Let me keep going here. Yes, very quick.
No, yes, but anyway, I think that if in the future we will know that there is a patient that has a lesion that will require, I mean, a lot of debulking before, it is possible that we can compare a little bit better the possibility of alternative approaches, including cabbage. I mean, we are talking about left main.
So let me keep going here. Let me keep your question. So we now show what the AI and the simulation predicted here. You see, it predicted this balloon, 3.5 balloon, this stent, 3.5 by 16, all the way to the left main at 12 atmospheres, and then the post-dilatation with pot. It's a simple left main, it's not a big deal. I'm sure that everybody here could handle this very nicely. And this is what the simulation, so now you see that taking into account this anatomy and biology, the simulation predicted that the one stent provisional approach with pot would work very well with good result in the circumflex as well. So that is the prediction essentially. And then now back to the cath lab, from the computer to the cath lab. On the top you see the prediction, the recommendation from the AI and simulations using digital twin. And bottom line is the clinical execution of exactly the same, pre-dilatation on the left, middle, same stent, 3.5, 16 megatron, and then finally the pot, exactly the same execution of what the AI and the simulations recommended. And then this is the final simulation, AI-guided PCI of the left main. And you see here by Yves, very good result, both angiographically and by Yves. And then you see here the flow now, before and after. Relatively good result in the flow to the circumflex as well. And here is now the question that many of us might have. How close is the clinical execution to the prediction? And you see here the difference. This is a MSD, the minimum stent diameter across the length of the stent, based on the prediction, the red, and based on the actual HD-IVUS with blue, difference 18 microns. So pretty close, the execution clinically to the prediction. So the question now that I would like to ask to Iles is, do you feel that this sub-millimeter accuracy in the range of like less than a quarter of a millimeter is clinically acceptable and meaningful? Would you like to see you would be more lenient and accept like even like less accuracy, have like the simulation as a ballpark and then do whatever you want, or you want to use the simulation as a benchmark against which you compete?
Okay. So I think that's a great question, and I want to back up for. Sorry, I don't want to like interrupt the flow here, but just to back up shortly, so when we're looking at this, how are we validate? Like, what's the verification or the validation around? Like, so we creating the model, and then the clinical outcome was the same. Is it because that was the clinical, like following the procedural development that you created, or you know what I mean? Like, are you creating your own model because you are following the steps that you told yourself to follow? Or how do we, you know what I mean? Like, how do we know it's not, we're not predicting or creating our own prediction?
Yeah, that's a very good point, actually, which is in this kind of like spectrum of discussion. There's two ways. One is to take the guidelines and have the model implement the guidelines, essentially. So based on what Goran said, this left main anatomy and so on, the guidelines or the recommendations are here. So make it essentially a tool that takes the guidelines into, you know, make it available to everybody. Or you can do something even more creative. Have this left main using AI being simulated with T, TAP, culotte, decay crash, provisional, in a matter of like 1 second, and then recommend what fits best.
That's awesome. Okay. Well,
and this requires obviously lots of computational data.
Yeah.
I was expecting you to come at some point.
Yiannis, can we see back the pictures and before and after in terms of this one?
The flow?
Puzzling on these pictures is what is puzzling on these pictures is the diameter of the ostium, what happens with the LCX. Look at that. I mean, is that the reality? I mean, that vessel is now narrow at the ostium on a quite long traject.
You talk about the ostial left main, right?
Yeah.
Yeah, this is as you know, this is the extension that the engineers create. It's an artificial, so the stent goes all the way to the ostium of left main. So what you see here proximal to the stent is not a vessel, it's the extension that the engineers create to create the inflow. So the stent goes all the way to the ostium of left main. There's no...
I was listening carefully to Yves, which has been passionate and on the ostium of the circ, and that I saw that, and immediately my reaction said, hey, something happens with the circumflex. And your explanation is that what you see on one panel versus the other panel is? This is lumen.
Say it again?
That's the lumen that we see
lumen,
there.
Yes.
So what is your explanation for this massive change?
The circumflex. Yes, the circumflex after pot became smaller.
Why?
It's part of the pot. It's part of the pot. All right. So that's the price of the provision.
Yeah, but that's maybe the answer to the question of Yves. I mean, if you negate the information which is visual, what is the power of that? I mean, that's the first thing that everybody will see, and you would say it's the model, fine, but there is a massive change there.
Yes.
And you have to understand that.
Correct. And now you have to make a decision if you want to escalate to a second stent or whatever based on what is the prediction, right?
But what is the mechanism?
What is the mechanism of that?
That's part of the discussion.
Yeah, that's the reason. That's the reason why I'm asking the viewer again the pictures. I mean, I'm here to learn, you know.
next year with the answer.
We'll try to get there. So let me keep going here because we need to. Yes.
So, well, I think we actually reach a very, very crucial point here because we have a model, we have a prediction, we actually follow the prediction, and we have a result that we don't understand, because this is not what we want the prediction to happen.
No, actually, this shows you that by executing the prediction, you ended up with a smaller ostial depth circumflex, and whether you accept it or not, it's a matter of an outcome discussion.
Oh, yes, but you see, when we see it, actually, when I see it as an interventionalist, I will see that part was not done correctly. So
maybe this is what we do every day.
The procedure might be actually predicted to use a pot, but if the pot is not done correctly, then what we see here is actually maybe a correct prediction, but a wrong performed procedure. And then we actually simulate that on the end and see, okay, yeah, the circumflex is actually compromised.
Circumflex is compromised by Iles at the end as well. The circumflex, so with this approach, with this this particular approach that we did today, the circumflex ostium ended smaller. Question is, do you accept it or not? Do you kiss or not? Different panel, different discussion. But the discussion today is that you can have a tool that can predict the outcome to the circumflex or elsewhere, and then based on this, you can devise the appropriate strategy. The discussion today is not to discuss how you optimize the left main PCI, what you do with if you have an ostial circumflex issue after the main vessel stent, whether you do routine kissing and so on. Obviously, this is a different level of discussion, and more to come on this. Yes, please, Yves.
I think if you have, let's say, 200, 300 cases of this simulation and the follow-up, clinical follow-up in the patient, you will have the answer of my question.
Here you go.
So it's maybe more urgent that defining with simulation which technique we'll use.
Correct.
You know?
Correct. So. Yes. Let me finish here because there's a little more here. But let me finish with this, and then we'll have a few more minutes for a final discussion. So, obviously, this AI guidance, again, I told you, it's going to be a little thought-provoking here, so it creates some discussion. It can help with personalized treatment based on the anatomy, increase efficiency because you go there informed to the procedure. It can boost the confidence, right? You know what to expect. It reduces the interoperative variability because I'm sure that many of us would do different kind of approaches, even with provisional. And of course, this advantage is that it can sometimes limit our freedom. Is there any liability issue? I'm sure there's a framework around, and then of course it requires some resources. So we're going to close the next 5 minutes here with some discussion on number one, and this I would like to go to Francesco for this, who is ready to make a comment. Do you really believe that we are ready to adopt an AI simulation-guided PCI in clinical practice?
So I feel that we are not ready because we should know the additional benefit of that. So I am not, let's say, open to change my practice for things that are not validated. So you introduced the concept of stiffness. I like this translation of, because I think that it is a step forward. If we compare the concept of seeing calcium in the imaging and then reacting, honestly, all the time in my practice, Goran saw last week, I try to test the compliance of this calcium with a non-compliant balloon. But when I do this, the PCI already started. So if I can know on advance the type of patients, the type of lesions specifically requiring demanding procedures with rotablation in both LAD and circumflex, probably in this kind of patients, I can have a better care. This means to plan the procedure when you have two operators, experts operator together in the hospital, eventually rediscussing the indication for cabbage and so on. So actually, we see these fancy images. They are, honestly, to me, because I like very much the images, I really love this kind of, I mean, Chiastra can say how much I know since the beginning of my training, but we need the data to understand this. Yep. I would know, for example, in this case, if you place the POT balloon in 3 different places, like we did into the Euro intervention consensus paper together, which is the impact of the position of that? And with that, you can come to the fellows and say, okay, you have completely different outcome for this circumflex and this lady according to where you will position the POT balloon. So please take care for 2-3 minutes to find the correct incidence. In other spots of the same patient, it is possible that you can post-dilate, liberally, without any problems, true problem in the outcome of the stent. And okay, this is also very important to know on advance.
Yiannis?
Yeah, well, I'll just say that I think we should have the comments from Tinen and from Nicolas. So, because we have to have all the parts of the discussion open. So, Tinen.
I was thinking more about answering that first question that you asked me, Yiannis, so sorry for distracting. But okay, so going back to how the question was, how much detail do we need in order for it to be clinically relevant, right, within the model? And I think a way that we could approach that is by doing a low a model that doesn't have a lot of detail, and then doing a couple different, I know that's a lot like computationally heavy, but doing a series within a sliding scale of a very computationally heavy model, and then moving through, and then overlapping that with what is actually needed for clinical relevance, and that way we can find that. And that I've done that in different ways in computational modeling, looking at, for instance, the detail of trabeculation versus just looking at the sidewall as being smooth, and how much does that affect the simulation. So I think we could do something kind of similar to that.
And Nicolas, let me pass let me pass it to you, because I think the question to you is going to be even more relevant. So do you see a day in real time that we'll be able to do this? Take all the data in real time in the cath lab?
I go short because I know Prof. Seris has a pressing comment. I think you need randomized data, that's for sure. And any form of AI technology need also reimbursement, because if you don't have reimbursement for that technology, you're never going to get any adoption. So I think that's my view. And yes, I believe it's going to come, and it's going to improve practice, reduce variability.
But Rick?
I think that Yiannis is a pioneer, and the pioneer have always a hard time. I'm a pro. I'm in favor of everything you show. But I try to understand. And I think that my colleague here said, did we see the angio after the procedure? I said, yes, we saw the angio, and then we saw the modeling. So on the angio, do you have this reduction, acute reduction, of the proximal part of the circumflex?
Yes.
Because the normal cardiologists would say, that must be spasm. I mean, what move in terms of metal or in terms of tissue? No, it should be something which is on a segment which was not explained. I cannot predict that reaction on what I have seen before. So my first reaction, and I would like to ask the panel, is that the spasm, okay? And then what you would do, you do extra nitrate, and if it's still there, I will look to my colleague and say, okay, what do about it? Do we improve that osteum, or do we respect? Is that a predictor of restenosis? That's really the type of question that you stimulate. Can we see again the angio?
No, because you want to distract the discussion from where we want to go. The truth is that the circumflex is not pinched, but it's compromised by angiography, by IVUS, and of course in the simulation.
Yeah, I mean, it's interesting because
that's part of the technique here.
Yeah,
it's always price of a pot. Maybe it's a dot here.
Yeah.
Maybe, but again, the question to you now, and let's close with this, we have one more minute. You have changed the landscape in many aspects over the last 30 years. Do you believe and do you feel that there's a need for a real-time, in the cath lab, guidance from AI?
Absolutely, absolutely. Whatever you can predict is good. And I think that the photo counting will be major in that field. That resolution of 111 micron, we introduced good garbage before, and you will have good garbage after. So I believe that it's coming. It's coming. And you are a pioneer in that field, it's okay. But I think that when you do a reconstruction with something which has a special resolution of 111 micron instead of 400, that's a major quantum jump in the future. So I think it will be there. But I'm coming just from a course of the fellow in Utrecht with the Dutch fellow. All the decisions were basically taken before the procedure based on a good IVUS, high quality, 60 megahertz, spectra wave, and so on. And basically, it was every time simple concept. I have 360 degrees of calcium. We go first for lithotripsy, no discussion. And nobody in the room was arguing with that. It was already accepted. When it was 180 degrees, 240, there were some people said, no, maybe not, maybe yes. But otherwise, criteria like 360 of calcium. So in your case, the roof of the LED was calcified, but not in a way where you would think immediately, I have to break that calcium.
Yep.
And that's the kind of prediction that you want to have. That's the kind of visual representation you want to have in advance. I'm pro, but it will take time. Like everything, 10 or 15 years.
All right, so I think that we're on time, and thank you so much for this discussion. Excellent, excellent.
This is Bifurcation Club.